If you see this is the muscular layer, it's now this is the lumina. So the lumina, you see what? There's erosion in this line epithelium primarily because all of these now are necrotic. If you breathe, this is portion of the muscular layer, and in the muscular layer you see the pigment. Okay, so that would be the pigment. Okay, so if we answer diagnosis, what is the etiology? Oh, okay, well, and that's with the pathogenesis. And in the pathogenesis, there are 5 things to remember. And what are these 5 things that you will have to remember? You'll have obstruction, you'll have impingement on the vascular supply. What else? You'll have ischemia, you'll have necrosis, and you will have female infiltrating that area. So question. You only have one question. Acute or chronic? So next question, why? If you tell me, doctor, this is acute because this is acute. Appendicitis is 0. Okay. So your answers must be the answer of doctor. You're no longer here. Because my problem with your the answers last time was the answers were more of personal answers rather than doctor's answers. Okay? So 80, if you tell me that it's not a doctor because of 80, it's not then that would be the wrong answer. So I will ask for clinical manifestation. What will be the findings in this patient? Gastric pain going to the right lower abdominal area. So what the famous area is? Right. Upper is so if you learn this when you go to examination, okay? So I'll ask you, what is describe the microscopic appearance? So here, describe the gross appearance. Okay. So look at gross and microscopic. They're 2 different things. You may have the right answer for the wrong question. Okay. Gross, if I ask for gross, then be gross. If I ask for microscopic, answer microscopic. I think you have 3 of superiority meningitis in your slide. Also, we have no superiority meningitis. Any question here? So, what time is that? Anyone would like Dr. Henry for the group? 33. Next.
This is a case of 2.5-year-old female child who was admitted for convulsion and projectile vomiting, which started a few hours prior to admission. She had a history of high-grade fever since 3 days previously, only temporarily relieved by antibiotics. Fever was associated with cough and highly febrile. She had neck rigidity and opisthotonus. The sign was positive. While in the hospital, she developed an episode of convulsion, became comatose, and later died. An autopsy was done. The brain removed and examined. It was heavier than normal, weighing 1.5 kg. It was edematous and congested, as evidenced by flattening of the gyri and narrowing of the sulci. Yellow purulent exudate with the subarachnoid space covered the convexity and base of the brain. Bilateral herniation of the cerebral tonsils was noted. Thick fibrinopurulent exudate is noted within the subarachnoid space. It is composed of fibrin, abundant neutrophils, and necrotic debris. There is also vascular congestion and thrombosis. The brain substance shows widening of the vestibular space, indicating edema and glial ganglion proliferation.
Doctor, so if I ask you, what is the cause of death? What will be the cause of death? What is the cause of death in individuals with meningitis? sepsis could be one, okay? The sepsis could be one. Question, what is the etiologic agent? Okay, speaking this is bacteria. For different age group, you will have different microorganisms. What is this age group is? So this is neonate. So you will have to remember what bacteria are commonly caused in neonatal types of meningitis. This is a brain tissue. So this is the area showing you the accumulation of the abscess material. So what is the component, or what are the components of abscess? Poison flash is the pinkish area, VMN, and necrotic debris. No? So these are the dead tissues, necrotic debris. Okay, so you remember, right? So VMN, okay, word, VMN wrong, but we polymorphism flash, we polymorphism related leukocytes. Okay, so we have to have the WB, so leukocytes again. Okay, so incomplete void. Go ahead, sir. Okay. Polymononuclear or nucleated leukocytes or WBC. Okay. You have fibrin flash, then you have necrotic debris. Okay. So that's what I've answered the question. So if I tell you that the patient had necrotic, necrotic tonus, and I ask you what is the diagnosis? I show you this. What is the diagnosis? It's important. Whatever appears here will be the acceptable diagnosis. So we won't have quarrels later. If you write so many things other than what is written here, it will not be accepted. It will be completely wrong. Okay? So for clarity and for uniformity sake, remember that. So this will be remembered for the diagnosis. Remember this thing. And I always have 2 points for the diagnosis. The other one is the type. What is the type of here? Appendicitis. Okay. Acute appendicitis. Appendicitis. Okay. Acute, so this is acute bacterial meningitis. Brain. So next, anyone? Next doctor, please. Number bronchopneumonia. Okay, 45-year-old. So, will you be able to identify this as the lab? Will you be able to identify this as the lab? So don't worry, no. When you go back to your slide set, you will have a better picture of that. So, I'm after the alveolar spaces. So, why do you have alveolar spaces in the lab? Why do you have alveolar spaces in the lab? Well, that is change. It can now be placed by the spaces contained by this class, necrotic debris, and mononuclear cells. Okay? So, this is why bronchopneumonia? Because the lesion is patchy. What do you mean by patchy? You don't see the entire involvement. Okay? So we no longer see lower type of pneumonia. We see now bronchopneumonia type of lesion. Okay? So question: this one problem of this patient. This one problem of this patient. Dyspnea is not a problem, this is a medical term. Again, look at your answer, no? So the question problem, so problem, dyspnea is a medical term. So what is the difficulty of breathing? So finally, also talking at you said dyspnea, this is a medical term. And for all you know, you may not understand what dyspnea is. But if you tell me, doctor, the patient that difficulty breathing, one of the kinds of bronchopneumonia. Okay? Etiology? Okay. So again, go back to the book and try to find out which is the more common type of bacterial infection. Okay? So how do we manage? How do we manage? Okay, so if this is fungal infection, if this is viral physiology, so antibiotics is used. Okay, so what is the answer? I will manage this case based on the physiology. And if to give you bacterial, antibacterial, then that would be wrong. Okay? So we go to the next. Doctor, kindly read. I'm standing. Yes, doctor. Read number 46, slide 46. Sorry, the same thing. Sorry, this is the same thing. Sorry. So look at the alveolar spaces. Which are supposedly you should be whitish, clear, because your air is found in this area. So look at what is happening now to the alveolar spaces. It's now filled with exudate, so much so that this patient will have difficulty of getting in oxygen. So we leave for 6 and for 7. We go to chronic cholecystitis. Yes, doctor. Number 36.
Hypochondria sometimes associated with low grade fever for the last 2 years. The pain was noted especially after having a meal sleep interest, physical examination, even the light tenderness and the muscles hurting over the right hypochondria. Program, even the nowadays, if we get defect in the gallbladder or polycystic hypertrophy or transform. While this ablation of the previous neuromuscular concentration, the more was taken several overshape like calculi with the manual surface and the ground on the form in the event to mucosal surface likely circulated. Microscopically, mucosal surface detect innervated integrally view of the areas like the projection, the venous channel are congested, there are diffuse cellular infiltration of the lymphocyte system, monocyte and the few plasma cells more concentrated in the lamina propria and the muscular layer becoming relatively scanty toward the many muscular fibers.
Okay, so we see what virus line projection, but we see when these projections are fused, you get spaces like this. What is the term for these spaces? The pathognomonification of chronic cholecystitis. What are these sinuses? Hey, it looks to be your alignment. Look at Robin. So, question. I give you this, but I will not ask for diagnosis. I will ask you for give one differential diagnosis. Give one differential diagnosis. Okay, so what is the manifestation of the patient? Abdominal pain, tenderness, gut muscle guarding, right? Hypochondrium. So I said appendicitis, flexible sedation, flexible sedation. So what will differentiate this from flexible sedation and constipative? Rotation to the back. Okay? So if it's rotating to the back, then you'll have to think of the chronic cholecystitis, especially if this is accompanied by pain following meal. Okay? So I know this is one of the really painful episodes. Sometimes the patient would have to be given something for the pain. Okay? You'll have to use no pain, so okay. Drug addicts in Cebu would be happy to have chronic cholecystitis. Okay? So next slide, yes, doctor. Your doctor, kindly, Doctor. Tapos? Sorry, Salari. Sorry, I don't know nag-last.
Dr. Salada, sorry. You were the one who did not write your complete name, minus 50. Okay? John Rose Salada. Okay? Dr. Salada, joke. Okay, so what could be the next? Can I touch the culture? Can I touch the culture? Yes, ma'am. Can you read? Another please. Another ma'am.
A 14-year-old male Asian man has been having recurrent epileptic bursts for several months. Initial gastrointestinal episodes have featured a gastric aneurysm on the left circulation. He was given medications for 3 weeks. There was no relief of symptoms and his gastrostomy showed no reduction in the size of the ulcer. Anti-rectal with gastrointestinal anastomosis was performed. The anti-rectal specimen showed a well-demarcated oval-shaped ulcer measuring 2.5 centimeters in its main diameter, with smooth, slightly rolled margins and cleavage. The mucosa immediately surrounding the ulcer is somewhat irregular. Microscopically, there is a great inconsistency of the epithelial line from the base of the ulcer towards the serosal surface. The following may be distinguished. A thin mucous layer forming a sort
Excuse me,
of
so we'll end up with that. So I will ask you, top to bottom to top, identify the layers of the alternation. So this is a nice picture. This is the normal side, and you see that in this area, we're able to appreciate the mucosal epithelial lining. Okay? So what you see now here is necrotic debris, and this is laptop. The question: identify the lesion. Identify the lesion. Identify the lesion. What is this lesion? Ulceration. Okay? So that is different if I ask you, give me the diagnosis. Because if I have diagnosis, you will have to point to that. So the diagnosis, that's the side of. So don't forget the side. Half of your classmates do not write side, so that's throwing away 1 point. Okay? Sometimes the 1 point you can difference 75 and 65, only 1 point. Okay? So every point counts. Okay? So what's top to bottom? So on top, what's on top? What's on top? So remember, necrotic layer, followed by inflammatory infiltrate, followed by granulation, followed by the fibroblastic surface. Okay? So what is granulation tissue? New blood vessel formation. New blood vessel formation. Okay? So the question is, keep one complication of this. You see, keep one complication of this. Perforation, death, size was terminized. So look at the question. If I ask for 1, give me 1, you give me 3, you get 0. Because you're not reading. This is my problem with getting a student, they're not reading the question. So do not over answer. Okay? You can over answer, under answer, get the same thing. Okay? Give me 2 complications. Peritonitis, death, and that is 2 answers. Another question, what is etiologication? What is the most common etiologication? So, cross. Why cross? Incomplete answer. Endococcus pylori, wrong spelling wrong scientific name wrong. Okay? So look at the book for the scientific names. Why? Because your doctors expect to have better answers from real doctors. Okay? So there are a lot of people who are trying to become real doctors, but only few of them become real doctors. Okay? So let's get next please. Okay, next. Yes, no, sorry. So now this is not punishment. So I would like to just contribute something for the class. So don't worry, that is not the punishment. So what's the next slide? So for after that, you will have the same thing. But we look at 83. So 83.
Six-year-old coordination, early developed male, child is largest in 15 years. Their examination of the body is visible for count in the lower extremity. Postmortem examination reveals multiple minute absent sacs in the lungs, kidney, and liver. In the lungs, the absent sacs are mostly subpleural. In the kidney, it is non-capillary, whereas in the liver, it is within the pericardium. Abscesses measured 0.2 to 0.5 cm in diameter and contains linear X-ray. Under big friction shows well-circular abscess surrounded by cytoplasm and capillary. The central area contains renal fluid and
So, for the three slides, you'll be looking at similar areas which are more or less necrotic debris. Okay, so this is not peptic ulcer. Okay, so I'll show you this. This is not peptic ulcer. Why? What I did. So this should be your clue that this is not gastric ulceration. This may appear like an ulcer, but it's not an ulcer. This is an abscess. Question. Define abscess. What is an abscess? Selection of parts. Okay. So next question. What is the most common etiologic agent? Yeah. Okay. So commonly abscesses are caused by bacteria. Okay. So those will be the answers. Okay. Now, what another thing to remember? Sometimes you will see in a portion in the middle showing purplish, grayish, purplish aggregates. What I did? These are bacterial colonies. Okay. So later on, when you go to the lab, look at the granular purplish material on the middle of the lesion, then these are bacterial colonies. So this would be your another clue that you're dealing with an abscess. Question: acute or chronic? Acute or chronic? Acute. Why acute? So this should be your answer. Dr. Herrera, this is acute because I'm seeing polymorphonuclear leukocytes or WBC. We kindly complete the word polymorphonucleation of nuclear leukocytes or WBC. Okay? Incomplete, 0. Okay? So things that I don't understand, 0. Okay? So if you write down this, sometimes you can also write this down. What is this? RIP. Okay? That's also the answer. Okay? So things that I can understand. So we have the last slide. So for the rest, kindly have a look at 84 and 86. Last slide. So, yes, doctor. Yes, please. For look. 11.
Scar of stage 4, a small nodule in the forearm of a 15-year-old student. Roughly, the specimen consists of a 3 by 2 centimeter skin fillet with a slightly raised gray-brown lesion in the center. Microscopic pigments show dense fibrocollagen, highly eosinophilic hyalinine tissues in the dermis.
So if you look at the tissue, it's one of the smallest, no? And this showing that I took my practical exams. I don't usually look at microscope, I look at the cross. So that will be a waste of time if you try to see things that you cannot understand. Okay? So if I see things, and I don't have to find the diagnosis. This is question. What is the predominant feature in this lesion? What's the diagnosis? What side? What is the side of the scar?
Forearm.
Forearm. So when you translate written here is forearm, okay? So scar tissue. So under the microscope you will see collagen fiber deposition or fibrosis. You see fibrosis or collagen fiber deposition. Okay? So How will it look? So it's looking at collagen, fibers, okay, so it'll be looking at broadband, like your cell phone. Okay. So, sorry, there's nothing in the design that will show you this appearance. Okay. These are collagenous tissue, broadbands of collagenous tissue, and this is scar tissue. Okay. So we'll have a short pitch before we get out. Okay. And let us split, any one particular paper will have a short width. Okay, you can open anything, but don't look at the answer of your classmate. So one particular paper, write your name. The question is, enumerate the three various